Really. Good evening, all. Welcome to iFocus Online Lecture 280, the 21st in the Uvea session. Today we have with us Dr. Sudharhan Sridharan from Nethralaya, Chennai, to speak to us to a very important topic, particularly with an Indian scenario in mind, the ocular manifestations of HIV. May I now request Dr. Dipankar Das sir to please introduce the speaker for today.
So you're on mute, sir. Pankaj, sir. Yes, sir.
Good evening, everybody. Today in iFocus Online, I'll be introducing my friend, Dr. Sudharhan Sridharan, who is a fellow, who did his fellowship in Uvea and Ocular Immunology from Sankara, Chennai, under Dr. Biswas, sir. Currently, he is senior consultant in Department of Uvea, Sankara, Chennai. He is the associate editor of Indian Journal of Ophthalmology and reviewer of international peer-reviewed journal. He has numerous peer-reviewed publications, and mainly his focus is on HIV and its related diseases. Authored many chapters in textbooks, and his areas of interest is uveitis, complicated cataract, HIV-related disease. He was awarded All India Ophthalmology Society and IGO Gold Award for the year 2020 on HIV and intraocular inflammation in the era of highly active antiretroviral therapy and update. Dr. Sudharshan will be presenting today the ophthalmic manifestation of HIV infection.
Thanks. Thank you, Dipankar. It's nice to be part of this iFocus, the most sought after PG program, I guess. And the way it's conducted, obviously, it's very tempting to be part of it. Okay. So, I mean, obviously, like I've spoken quite a few times on HIV and ocular manifestations of HIV. So it's good to have enough time when you're always given minutes on stage and on in front of the mic. Now we have a lot of time, so we'll try to see how slow can I be. So before anything, like let's have a disclaimer. So people keep calling the HIV man and so many things. So I'm not specialized in HIV disease. I've seen quite a few patients with HIV and ocular lesions. So most probably, importantly, I'll be talking about the ocular manifestations in relation to uveitic manifestations in HIV. The corneal, adnexal, and orbital lesions, we'll leave it to those specialists. So we'll see HIV-associated uveitis predominantly. So this is probably, I should call it the gold standard now that I've been introduced as a person who's won the IGO Gold Award. So this I've taken liberally from these two articles. It's like kind of self-acknowledgement or boasting, however you want to take it. So HIV and eye lesions, so we'll try to classify them into the ones which are attributable to HIV. So they can be because of HIV itself, which is very uncommon, or because of those opportunistic infections. These are the most popular and devastating ones, which we are always worried about. So HIV-related diseases, it can be directly attributable to HIV or not directly attributable to HIV. There can be some diseases in patients with HIV, I mean in the eye, which can be because of the drugs. So the drug-related ones, which can be because of the recovery of immune status of the patient, the immune recovery uveitis, or the heart-associated ocular lesions. So the drugs which are used in the treatment of HIV systemic disease itself can cause ocular manifestations. We can also have some drugs which may be used in the treatment of the systemic opportunistic infections like TB. So something like ethambutol, these can also cause ID lesions. We'll have a look into those. And there may be some others which are not very sure which they belong to any of these. The first of all, when we start off with the ones which are done, which are because of HIV itself. So the HIV-associated microangiopathy. This is the most common or the most popular one, if you want to call it, because this we've been reading about it from our MCQ days. So we've always been asked which is the most common ocular lesion in HIV retinopathy, and which is the most ocular opportunistic infection common one, CMV retinitis. Used to be always making a mistake among them. So HIV-associated microangiopathy, relatively a benign one compared to what we come across in other HIV patients. So when you look at CMV retinitis or other infective opportunistic infections in the eye, HIV retinopathy is a relatively mild one. It comes with corneal spots, retinal hemorrhages or microaneurysms. In fact, initially Dr. JB used to tell me that when they used to see all patients with HIV, the fundus examination, they used to keep thinking that how come every other patient seems to be having diabetic retinopathy or hypertensive retinopathy. So they used to be thinking that every HIV patient will have diabetes or hypertension. Then they realized that somebody in US, Jabs and others probably reported ocular lesions in HIV and which were HIV retinopathy. So Dr. JB got excited, and obviously he reported the first ocular lesions in HIV from India. So the corneal spots, the retinal hemorrhages and microaneurysms are commonly associated with HIV retinopathy. They usually don't cause any visual impairment, but sometimes there have been reports of they causing some visual field defects. Whether these visual field defects are directly because of these aneurysms or corneal spots or in ischemic areas, we don't know. But it has been found that there can be some risk factor for retinal vascular occlusions in these patients. They can also cause ischemia at those areas, and that area are relatively more prone for the retinitis in future. So probably this way, these are causing visual function defects rather than visual acuity defects. HIV retinopathy can be an indicator of the therapeutic failure, because most of the time HIV retinopathy is not seen when the patient's CD4 counts are much higher. And the patient is on regular heart, when it is when the compliance is good, it's usually we don't find this HIV retinopathy. So they are associated with lower CD4 counts, and you don't need to treat them specifically for that. It resolves very well with improvement in CD4 counts. So remember that you can sometimes mistake these kind of larger lesions as coalesced corneal spots. So you have this scar there next to this spot. So probably that's an indicator that this is not a corneal spot. This was a patient which was referred to us as with a posterior pole picture alone, or undilated, somebody had examined and sent to us as corneal spot. But then you found that there was some retinitis at the periphery. So coalesced corneal spots in HIV retinopathy can be mistaken, or the other way around. Retinitis can be mistaken as a coalesced corneal spot. So beware. It's very important that you don't miss a granular type of CMV. What is granular type of CMV? We'll come to it later. So periodic fundus examinations is a must. So HIV retinopathy is a benign lesion, but in some patients, they can have, because of the endothelitis, multiple infarcts or capillary non-perfusion areas everywhere. So this is one patient where you can see that at the end of it exactly, like there is no flow of the dye at all anywhere. And this capillary non-perfusion areas where in this patient was associated with multiple infarcts in the brain. These are rare instances. It is not that every HIV retinopathy you should lose your sleep over and get psyched about it. So most of the time they're benign. You treat them, follow them with regular heart, they get okay. But also follow for some visual field defects, and they might have some multiple infarcts in the brain. So among the HIV itself causing the disease, there is something called HIV-induced uveitis. See, in any HIV patient coming with eye inflammation, so the first thing you'll have to think is probably an opportunistic infection which is causing the inflammation. So most of the time that is the cause, but sometimes HIV itself can be the cause for the uveitis. So this is due to the direct effect of HIV itself and not due to any opportunistic infection. So remember, I'm repeating it again, any inflammation in a HIV positive patient, rule out infection first, but there is a possibility that it can be because of the HIV virus itself. So suspect HIV-induced uveitis in patients who are heart naive, means who never had heart before, who have low CD4 counts, or who are non-responders, who've been on heart for long, but they don't seem to be improving their immunity. These are mild reactions, usually anti-uveitis, and without any ocular lesions. So you might be wondering sometimes that the fundus is normal, otherwise there are no major KPs, no mutton fat KPs or otherwise AC reaction. Patient has low CD4 counts and not on heart, but still having inflammation. This can be probably because if the patient's CD4 counts are higher and having inflammation, then you might think of ruling out other possibilities. But in HIV-induced uveitis, the inflammation occurs when the counts are low. That is the way you differentiate between a patient who has immune recovery uveitis. And immune recovery uveitis are those in patients who are on heart and whose inflammation occurs when their CD4 counts are higher and correspondingly low viral loads. So any patient who has inflammation with higher CD4 counts with low viral loads, you are probably thinking of a patient who has immune recovery. A patient who has low CD4 counts and inflammation and no other ocular opportunistic infection, then you are probably dealing with a patient of HIV-induced uveitis. How do you diagnose? It's a diagnosis of exclusion, but we try to do some study where we try to do the AC tab for these patients because we had to rule out what is the cause. Patient was persistently having significant inflammation, and we found that RT-PCR viral HIV copies were much higher, while VZV, HSV, and all the known infective viral copies were negative. So that was an indication that this was probably caused by HIV uveitis itself. There are few patients with whom we had at the follow-up, and HIV load had significantly reduced with improvement in CD4 counts. So that way, this was a diagnostic and useful indicator of doing RT-PCR copies in these patients. These are rare ones. So remember always that HIV-induced uveitis is a diagnosis of exclusion. So any inflammation in HIV, rule out infectious cause before thinking of immune recovery uveitis or HIV-induced uveitis. So we saw those attributable to HIV, which can be because of HIV itself, either the HIV retinopathy or HIV-induced uveitis. The most dreaded and the most popular one, or which everybody are scared of treating, is opportunistic infections, which cause visual loss, which are severe. We are talking about heart, and there have been multiple generations of heart. So, but still, like opportunistic infection is the major cause of visual morbidity in HIV/AIDS individuals. So you might find newer lesions, or probably you find newer manifestations of these old known infections. The same CMV or syphilis or something can present to you in a different way or some modified way, or partly because of heart, partly because of the newer modified immune system. So sometimes you might get newer infective lesions also in the heart area. So we'll see how are these. So I had actually promised you all that the adnexal and other things will be covered by corneal and adnexal people, but just to mention fleetingly, the ocular adnexal complications, when you see adnexal complications, they can be sign of a severe systemic immunosuppression. Patient probably has an OSSN or some corneal lesions. You always keep wondering if the systemic immune status is very poor. So when you look at these patients, one important thing about these anterior segment lesions in HIV is that most of these lesions occur when the CD4 counts are more than 250, while adnexal complications seem to be occurring when there is systemic immunosuppression is severe, but corneal and other anterior segment lesions occur when the counts are higher. Posterior segment manifestations occur when the counts are much lower. Sometimes these can be the first presentation of HIV itself. Almost in our study, about 15% of the patients, we found that this was the first presentation of HIV. And OSSN, about 12% of these anterior segment lesions were OSSN. So this is one thing that is very, anybody diagnoses as soon as they see it, or sometimes the only problem is when they come with healed ones or scars, the scalding, sometimes you can miss, and you'll have to be very careful. Herpes zoster ophthalmicus. So it's almost an equivalent form of CMV retinitis for the anterior segment part, because when you think of posterior segment, you think of CMV retinitis. When you think of anterior segment in an HIV positive patient, you think of herpes zoster ophthalmicus. So these herpes viruses, I was just mentioning that anterior segment lesions occur when the counts are higher. The same herpetic group of viruses can cause ARN or PRN when the counts are much lower. It can occur at the ophthalmic division, but sometimes remember that it is not necessary that it needs to be the first division of the trigeminal nerve. It can be the maxillary division also. So in HIV patients, it can be at the ophthalmic division or the maxillary division. The treatment is the same. You need to give systemic acyclovir full dose for about 3 to 6 weeks. Make sure that you're not missing out on any associated dendritic-form or stromal keratitis. They can come with very mild conjunctivitis or blepharitis. Hypertensive uveitis is an indicator. The patient who might have had a mild form of HZO, you might miss the scars, but can come to you with uveitis with raised IOP. So look for these scars, especially if the patient is immunocompromised. You know that, sorry, you know that any uveitis with raised IOP, you probably need to think of viral uveitis as the first cause. In immunocompetent, otherwise you think of probably Fuchs or Posner's Schlossman. But in HIV, one important thing you need to rule out is ask the patient if the patient had a past herpes zoster, ophthalmicus, or any scars or any lesions in the forehead, especially, or at the hairline. Hemorrhagic hypopyon, sometimes obviously we've been taught from undergraduate days that hemorrhagic hypopyon is an indicator of viral uveitis. Scleritis, retinitis, and encephalitis probably are very easy to diagnose straight away. So remember, herpes zoster ophthalmicus, the diagnosis is clinical. Want to add these kind of pearls of wisdom, because I was just talking with somebody in the afternoon and they said we need some pearls of wisdom of HIV. So probably we thought we'll add some pictures about this. So the diagnosis is clinical, but most of them want you to answer Hutchinson's sign. So when there is a vesicle on the tip of the nose or on the side of the nose, this indicates that the zoster involvement is of the first branch of the trigeminal nerve. So this is a very popular and common question, so which it will be good if you answer, and definitely not so good if you don't. So any patient who has a vesicle on the tip or on the side of the nose, you have to be very sure that you will examine the eyes, because there is a possibility that the ocular involvement is maximum. And again, any middle-aged person with HZO, suspect immunocompromised state. So among the anterior segment lesions, the most common one is herpes zoster ophthalmicus. Another one which can come in children and young adults is the molluscum contagiosum. You might find these wart-like or umbilicated lesions. The umbilicated lesions is the diagnostic feature of these. So look closely. So about 5 to 18% of these HIV infected patients in most studies have had molluscum contagiosum in the past, but now it's much lesser. Like, we've not been seeing that often. We used to be seeing quite a lot of kids, especially being brought with these. Like I've seen in the HIV clinic, they trying to cure, excise and curettage those things, but this is not so common nowadays. With heart, definitely it has come down, but on and off these things prop up, reminding us that you may think of COVID and other things, but HIV tries to keep telling you that, like, no, I'm still there types. So molluscum contagiosum manifests definitely much more aggressively in children and young adults in immunocompromised. They are much larger. They combine with each other. These lesions, they get confluent, and many times it can be very resistant to therapy and all over the face, and it can be bilateral. So they say these are more common in HIV infected individuals because of the profound dysfunction of the T lymphocyte mediated immune response. So whatever is the cause, you need to remember that molluscum contagiosum is fomite transmitted contagious disease. So be careful when you're handling them. In children and in adults, molluscum especially involves the lids and conjunctiva. Face, trunk, and genitalia are most commonly involved. Heart actually helps resolution of molluscum, but when they are large, probably topical phenol or trichloroacetic acid helps. There have been various methods of treatment. People have tried applying serial applications of liquid nitrogen. So incision with or without curettage or excision or cryo are helpful. There are multiple newer studies, so maybe you can go through them. So people have even tried topical or intravenous cidofovir, but that's very uncommon. Cidofovir otherwise causes a lot of problems in the eye. So I'm somebody who's very scared of this. So better to avoid those things. So remember that the important thing about molluscum you need to remember is that the distribution is classically called in the chin strap region, which is most common in HIV positive patients. So sometimes, like I just missed out once one molluscum, and that was one of the reason I specifically wanted to add this line, which is there in the text anyway, that the last line should be examined carefully in all these patients. So we've had these famous presentations by Dr. JB about chronic conjunctivitis being there in HIV patients, and one of the patients which I saw had a chronic conjunctivitis, and I thought, okay, like even I'm seeing the variety which he has seen. And then suddenly I see that there was some wart or something which the patient actually showed to me. Otherwise, I would have missed it. So remember always that the last line is most important to be examined, because sometimes there can be some 1 or 2 lesions which you might miss out. So HZO, molluscum are the anterior segment or the adnexal lesions. So the other one which you need to think of is ocular surface squamous cell neoplasia or whatever. So Kaposi's sarcoma used to be very famous those days, but even I haven't seen any. I have seen one with probably with ENT involvement in Kaposi's, which is not an Indian, because usually they are seen in African population probably, because we don't seem to be having this human herpes virus 8. So this Kaposi's probably is not seen in Indian origin people because of this less prevalence. So this is almost 1/5 of all the malignancies, and 1/3 of all patients with HIV seem to be were getting Kaposi's in the past. And initially, it was noted in these renal transplant patients, and that really is aggressive and disseminates rapidly. Squamous cell carcinoma, people have misdiagnosed it as pingicular, pterygium, and so many other things. Incision and excision biopsy are diagnostic. You can excise with amniotic membrane grafting, treat it like any other OSSM disease. But most importantly, in HIV patients, the recurrences and other things are much lesser. There have been large studies from, especially from LUP and other places, where they've shown that heart itself can resolve significantly. Adjunctive therapies like cryo or chemo are very essential because they are life-threatening. So we saw the anterior segment manifestations, opportunistic infections, predominantly herpetic. So you can also have the herpetic keratitis ones. You can have microsporidiasis, which is another one, can have a stuck-on appearance, they call. I really thought one of my patients were foreign body all over scattered. I really thought he's who somebody works as a welder or something. I kept asking him something fell in your eyes, and then I asked our cornea colleagues initially about 15 years back, and who told me that no, this is what you call it as a microsporidias stuck-on appearance or something like that. So we leave it to them for treating them. But one you need to remember is microsporidia may be uncommon in immunocompetent, but definitely much more common in immunocompromised. So moving on to the posterior segment, so you're always thinking of retinitis. The more colorful yellow things in the fundus are usually in HIV related eye diseases and probably diabetic and maybe some medical retina, all these issues. So one thing that can excite anybody is seeing some yellow red in the fundus, but unfortunately these are vision threatening for the patient. But when you see a retinitis or a choroiditis in a HIV AIDS patient, so what do? So this is the classical picture, classical pizza pie appearance. If you have a retinitis, with lots of hemorrhages, and if the CD4 counts are much lower in a HIV positive patient, then you are thinking of, you're dealing with a patient of CMV retinitis. The CMV retinitis is the most popular, most devastating also. So anybody, this is a very classical picture. Most of us have brought up with these kind of pictures of CMV retinitis. So retinitis with hemorrhages all over in a HIV positive patient, or otherwise a patient presenting to you like this, who may have come to you as the diagnosis of an inflammatory BRVO and things like this. I'm sure most of you would have come across some time where you have a retinitis with hemorrhages, and somewhere somebody would have treated it as an inflammatory BRVO. So a picture like this, even if the patient is non-HIV, then you ask for HIV testing. So this is the classical CMV retinitis picture. Not all patients with HIV get CMV retinitis. There are some genetic susceptibility characteristics, and there are some possible risk factors of HLA typing. So you can read about it, but it's not so significant as it. CMV retinitis not always comes like this. We just saw this picture when we are talking about HIV retinopathy. A pizza pie appearance or the hemorrhagic type of CMV retinitis looks like this. This is the granular type of CMV retinitis, where you have this powdery kind of appearance, but this is also active. So CMV can be a hemorrhagic type of CMV retinitis with a brush fire kind of spread, which is the classical presentation, or the granular type of CMV. Don't miss this as something that has healed. You can have a sheet-like without hemorrhages, fibrosed, scarred lesions like this, which are healed. But when you have a powdery granular appearance like this, they are active. So you need to treat them. Remember that CMV can come without hemorrhages also. So how do you manage CMV retinitis? Remember that all these diseases are opportunistic infections. It means that they come when the patient's systemic immunity is not so good. So these are systemic diseases manifesting in the eye. So I used to be going to this HIV clinic. So for about 10-15 years, we were like screening patients there. And all these inpatients when we were seeing, they used to be specifically asking us if there is CMV retinitis in some particular patients. So I used to be wondering, like, Why are they so particular about those particular patients when most of this inpatients are having low counts? Then they started telling me that these patients have dysphagia or some pneumonitis which they are not able to make out. So a CMV in those days used to come with CMV esophagitis. So these patients will have difficulty in swallowing. So instead of taking a biopsy from the esophagus or the lower end of the food pipe or from the lungs, so they used to ask us if there is a CMV retinitis. So if at all we find a CMV retinitis, they used to correlate and tell that probably all the things are related to each other. So that was one thing that we used to help the systemic infectious disease person with our eye examination. Anyway, so coming back to CMV retinitis, so it is a systemic disease manifesting in the eye. So you need to treat it systemically. So it is not enough if you give intravitreal ganciclovir. Remember that we've also treated some patients with intravitreal ganciclovir because of resource constraints, but that's not the best or the ideal way of treating it. IV systemic ganciclovir is the best. So ocular manifestation of systemic disease, so treat it systemically. So people talk about valganciclovir being a pro-drug. Yeah, it is a pro-drug. It is equivalent to ganciclovir IV, but remember that it is not equal to IV ganciclovir. If at all you have some inpatient, management difficulties, then valganciclovir is a good alternative. So IV ganciclovir 5 to 7 milligram per kg body weight. We actually give about 250 milligram twice daily for about 1 or 2 weeks, followed by maintenance or the oral drug. Or if in case you're not able to give systemic IV, then probably you can start off with a 900 milligram twice daily valganciclovir for 2 to 3 weeks, followed by maintenance. On and off in between, you can augment them with intravitreal ganciclovir. So intravitreal ganciclovir induction is bi-weekly and maintenance is once weekly. So you can supplement IV ganciclovir or augment the treatment of systemic ganciclovir or valganciclovir with intravitreal ganciclovir. It definitely gives enough drug in the space where the retinitis is there in the vitreous cavity. The drug acts on the retinitis faster and it definitely resolves well. I've not seen any patient with Vitracet implants. We don't have it in India that much. Otherwise, the first generation was shorter acting. The second generation is an implant with a longer acting drug release system for about 3 years. I don't think it is that very useful nowadays, but especially it may be useful in these iatrogenic immunosuppressed patients, which that is what they commonly use nowadays, because they may not be tolerating systemic drugs or they may have some side effects for the systemic ganciclovir. So in these patients, the local implant may last for longer and it may be helpful. So one thing you need to think of is, so when you look at these pictures, the media clarity is so clear. So it looks so very clear. Most of these HIV patient pictures, the fundus pictures are so very clear. That's because they don't have vitritis. So if a patient has CD4 counts low, then the vitritis is much lesser and you cannot have the picture that very clear. But with heart and modified immune system, sometimes it is not necessary that the CMV retinitis follows the textbook so well. Sometimes you can get CD for CMV retinitis today, even at accounts higher of 300. See, it makes sense, isn't it? Like when you're looking at patients with renal transplant or some patients who are on chemotherapy, it's not that their CD4 counts are going to be 100 or less or something like that. So they may have some CD4 counts much higher, but even those patients sometimes get CMV retinitis. So it is not unusual or uncommon for a patient presenting with CMV retinitis if the counts are more. But remember one thing, that they may not be the classical appearance which you are always accustomed to seeing. An active CMV with inflammation can occur even in patients who are on heart. They may present with frosted branch angiitis. It's almost like an immune recovery vasculitis. So if you have a retinitis, vasculitis, or frosted branch angiitis, probably you're still dealing with the patient with CMV retinitis today in the era of heart. So in those days, we used to be seeing quite a lot of CMV with RD. So, but nowadays you can even see exudative because of the immune recovery. It can be tractional or reg. The retina can be lifted from the edge of the scar sometimes, so you can get any type of RD. So the pre-heart reg RD, almost 1/3 of every patient of CMV used to get, but now it's about like 6%. That's what the studies say, like much lesser. You may get RDs more often in herpetic ARN or PRN related or toxo maybe sometimes, but not in CMV. That very common. It's not that it doesn't come, but it's relatively less. But obviously, like any surgery in a viral retinitis patient, when you're doing surgery, then to stress upon the fact that you need a higher century silicone oil. Initial days, they were actually doing very well. Of course, surgery, the CMV ones, we are always used to be comparing between the ARN ones and the CMV ones, and CMV ones used to do well. But now with the heart and immune recovery uveitis, sometimes they can also react very badly post surgery and can result in PVR and other exuberant inflammation. So recurrences are much higher nowadays. So the good thing about the heart is that immunity improves, but the bad thing is all the other side effects come along with it. It's a bad package anyway. So remember that CMV retinitis is the most popular. The other herpetic group viruses like HSV-VZV, they can cause acute retinal necrosis or PRN or progressive autoretinal necrosis. I think they named it correctly. The cracked mud appearance. So this is the classical description of progressive autoretinal necrosis, where the vessel sparing and all that. So IV acyclovir or valsiclovir is the treatment of choice. So remember, I'm not going into the details with all the tabular column of HSV, VZV, or ERN, PRN, CMV retinitis, the most popular table going across everywhere. So as PGs, I guess they need to know the difference between them. There'll be some interesting examiners who want you to enumerate each of them. So remember always that ARN and PRN can be caused by HSV, VZV. And now with the new Sun working group classification, so CMV and classical ARN appearance because of CMV is not called ARN. So CMV retinitis is a different one, and HSV, VZV can be called ARN. So we saw about CMV retinitis. So remember that any retinitis in HIV patients is not CMV. That's one thing. The one advantage of being a HIV specialist is that when everybody makes a diagnosis of CMV, you want to make another one. So it's not the only retinitis. When you have retinitis with hemorrhages, this is CMV. You have another one, that's again CMV. But when you have this bleached kind of appearance, where you have some hemorrhages, but not too many, but then you have some retinitis, but it's not as severe as the other one looks like this. So it can be probably a toxo. So I was just telling that when you have a retinitis with hemorrhages, then it's probably CMV. But when you have a retinitis without hemorrhages and a granular appearance, it can be the granular type of CMV retinitis. But when you can have not so granular retinitis, and you can have some hemorrhages, and if you find anything like this in a patient with HIV, then probably you are dealing with toxoplasmosis. So toxoplasmosis is the second most common necrotizing retinitis or retinitis like lesions in HIV positive patients. Remember this vessel. One important thing in atypical ocular toxoplasmosis is that they can be unifocal, not necessarily. If the counts are good, they can also present like headlight in the fog appearance, like how you see in immunocompetent patients. But more often they are multifocal, and the media clarity is so clear. So, or the necrotizing retinitis types. So, almost always in immunocompetent, toxo is a diagnosis clinically that is made. But in immunocompromised, sometimes because they are atypical, you might need to do the ELISA antibodies, or they definitely have a high positive predictive value. If they are negative, that doesn't rule out, but if they're positive, then definitely you need to value it. Initially, they used to be neuroimaging almost every patient of toxoplasmosis because of the Western literature, which showed that among the CNS manifestations, toxo was almost among the top in the list in their population. But that's not the case with us. We were also in our centers also, they were doing almost about in 1/3 of the patients who had severe systemic diseases, but now we no longer do it. Probably in select cases, you might think of doing a neuroimaging in ocular toxoplasmosis. You treat them with pyrimethamine or sulfadazine, or like how you treat in immunocompetent, a sulfonamide or a non-sulfonamide, a combination, along with probably low-dose steroids if there is inflammation or if the counts are more. So one thing you need to remember is that they can be as extensive and diffuse like any other PRN or ARN also. This was one elderly lady or a 55-year-old female who came to us with this kind of a presentation. This was really atypical. This was really atypical with not many hemorrhages, not the typical necrotizing retinitis types of one quadrant or one arcade. So we had to do an intraocular specimen evaluation. Blood ELISA and AC type both confirmed the diagnosis of toxoplasmosis. So in these kind of situations where it is so aggressive, you can definitely add intravitreal clindamycin. So those were the days we were not adding clindamycin that routinely along with the systemic, but then intravitreal clindamycin definitely helps in the faster treatment of these lesions. So Toxo can be like this, multifocal lesions or necrotizing retinitis types, or can be had late in the fog appearance, but can sometimes be as diffuse or extensive like this, which you might need to treat them with aggressively. You may miss out these chiral kind of arteriolitis initially, but when the things resolve, it might be seen much better. So remember that ocular toxoplasmosis can present differently in HIV/AIDS patients. See, vitritis, I was just telling that in HIV positive patients, you don't find that much of vitritis when the counts are low. But there are two diseases you need to remember always, that despite low CD4 counts. See, if you have low CD4 counts, the patient may not have inflammatory reaction. But despite low CD4 counts, if there is significant vitritis and if there is a retinitis, then you need to rule out either it is toxo or syphilis. So syphilis and toxo can present with significant vitritis despite low CD4 counts. So in these kind of situations, aqueous tap or with biopsy with PCR may be quite useful. You can try out AC tap. Most of the time they really are helpful. So uncommonly they can be extensive necrotizing retinitis types. So when in doubt, aqueous tap evaluation. So we saw CMV retinitis, we saw toxo. So what are the retinitis? This is again another atypical one, but there is some vitritis. Patient has some panuveitis, some vasculitic lesions. AC tap we did, negative for all. So if you have an atypical presentation, we do AC tap, negative again. But then there are some placoid or some choroidal lesions. So if you have these multiple combinations and it confuses you, then you make a diagnosis of syphilis, more often than not, you'll be correct. So this was a patient who had come to us with low titers and titers. So we hadn't done the VDRL testing earlier. We did an AC tap, but simultaneously by the time we got the reports of everything, we found that the RPR TPH was also raised. And so it's syphilis. When you have atypical necrotizing retinitis, one of the DD is syphilis. Definitely it is probably higher in the list nowadays. You treat syphilis like neurosyphilis. Panuveitis is the commonest. It can have varied presentations. The initial description of syphilis was the placoid chorioretinitis. So placoid chorioretinitis can occur in higher CD4 counts, but remember that in HIV patients, when they are with low CD4 counts, the necrotizing retinitis mimicking CMV or toxo is more common. So again, as I said, you can have significant inflammation despite low CD4 counts, then you are thinking of syphilis. So treat it like neurosyphilis, and in select situations, you can do neuroimaging. Syphilis can definitely recur, so and they can also cause immune recovery inflammation. So have it in mind. You can have retinitis. You can also, when it resolves, present like a localized RP-like picture or salt pepper retinopathy. A patient may not have a overall RP-like picture. Wherever there was retinitis, when that point resolves, then that can look like a localized RP. The characteristic atypical presentation, if you can call it that way, in syphilis is these kind of deposits. So if you have these kind of deposits or posterior hyaloid phase or retinal deposits, then you are again dealing with a case of syphilis. These are more diagnostic, you can say. One thing you need to remember that all this old teaching of syphilis occurring in primary, secondary, tertiary stages, or specifically this stage, that stage, they're all like, they don't follow them. Now it can occur probably in any stage of the systemic disease, or it can be the first presentation also. The characteristic, there are no characteristic presentations of syphilis. They're atypical, both in immunocompetent and immunocompromised. And there are some at-risk groups, especially MSMs. So these are more at risk. So I was talking about placoid lesions. If you find, then they are probably dealing with syphilis. But then in those days, there used to be one disease which they used to be worried about with placoid lesions. That is pneumocystis carinii choroiditis. The nearest differential diagnosis for any placoid lesion is pneumocystis. So again, like if my generation people, I don't know what about the multiple choice questions nowadays for PG entrance. So it used to be this question that why pneumocystis carinii choroiditis occurs, but they don't get the pneumonia. That's probably because they used to have some pentamidine prophylaxis. But after this Bactrim or cotrimoxazole prophylaxis, we don't seem to see this pneumocystis. We don't call it carinii anymore. Girovici choroiditis. Finally, about the posterior segment lesions, TB. So what's special about TB in HIV? I'm not going into too many details. We are like enough confused about TB and immunocompetent. Like obviously we had a great talk on TB and uveitis by Dr. Vishali, clarifying most of our doubts. You can get atypical, asymptomatic choroidal granuloma in HIV positive patients. As long as they don't involve the posterior pole, they can be.
You just dump everything on my head.
I am putting the drop. I am given the serial.
nice to know that Dr. JB sir is there around. So choroidal granuloma, asymptomatic choroidal granulomas, if they're not in the posterior pole, then probably you may miss out, the patient may not complain. So I used to be seeing quite a lot of these patients when we used to go for the screening of these patients of inpatients in HIV clinic. So there used to be multiple atypical choroidal granuloma, or they can come to you with large subretinal abscess or a scleral abscess. Important thing to remember about TB in HIV is that they can be part of your disseminated systemic disease. So there is no specific correlation. So we are talking about, say, CMV or PRN, where you get these lesions where the counts are much lower. But TB in HIV occurs in all ranges. It can occur in different forms as a granulomatous uveitis or a subretinal abscess or a scleral abscess based on the counts, or it can be asymptomatic choroidal tubercles if the counts are much higher. So ocular course and systemic TB course may not coincide. Probably there is a problem of the ATT not crossing the barrier. So that's what we thought we found in our study. So HIV positive patients are much higher at risk for multi-drug resistant TB. That you need to remember. So gene expert analysis routinely they do for identifying the group. See, all other HIV patients, like if the patient has CMV retinitis, you start them on heart as soon as possible. The toxo maybe you need to start, but TB is one thing where the ART initiation and HIV patients with TB has some guidelines. So when do you start ART? So if the counts are much higher, you can try to defer the starting ART, but start the ATT. This is because patients with TB uveitis or TB ocular lesions, if you start ATT and ART simultaneously, they can develop paradoxical worsening. So what if there is a worsening in a case of suspected TB? First of all, obviously, like you need to revisit the diagnosis. You might probably dealing with a wrong diagnosis. But if the diagnosis is correct, then you start thinking if there is some insufficient anti-inflammatory therapy. But the most important thing you need to rule out is paradoxical worsening or a drug resistance. So remember one thing, there's something called paradoxical worsening in a case of TB. It can occur in syphilis and other things. They used to be calling it Jarvis Heshimer or some reaction. So paradoxical worsening of TB infection after heart, it's because of the immune response of the host that improves because for the TB antigens, and they can have devastating complications. So they've made some guidelines where if the counts are much higher, then you can wait for enough ATT and the TB load to come down. I mean TB organism load to come down, and then start ART. If the counts are lower, then probably you can. There's no choice. You'll have to start ART early because you need to save the life of the patient. So remember that we saw retinal choroidal lesions, and these are not the only ones which happen in HIV patients. So, and to please our neurophthal guys, obviously the neurophthalmic manifestations are more vision threatening. I mean, the disc is gone, everything is gone. You may treat the whole of retinitis, and then like if you give a white optic nerve head, then that's worse. It can be because the common manifestations can be optic neuropathies. So as again, we used to be seeing more often these neurophthalmic manifestations in the non-ambulatory or debilitated patients. But now with patients walking into your clinic, so you don't see these neurophthalmic manifestations in your clinic that often because they are patients whose immunity are better. But when you go to the HIV clinic, you really still find these patients with neuro manifestations. Optic neuropathies are quite common. Papilledema is the most common, obviously, like any other thing. So it can be because of direct or consequential to any of the opportunistic infections. So there have been studies from South where the HIV itself causing optic neuropathy and resolution with the heart also. So I was just talking about why they were doing MRI in patients with ocular toxoplasmosis. This was the reason. So toxoplasma was the most common CNS manifestation in their studies, but for us it is crypto. So cryptomeningitis was the most common, and cryptodiscedema or cryptococcal choroiditis, these kind of lesions were more common for us in patients who have neurophthalmic manifestations. There can be some rare ones like this, where this was one young guy who came to us a day before or something, one day before with some somebody called up and said has some vision disturbances, and in 2 days he really lost vision, and in a week or 10 days time, or like within a few weeks, he lost his life. So this is a rare presentation of PML. So this is which is very uncommon without focal neurological deficits. So this is very difficult sometimes for you because you might miss out. Usually they involve the temporal lobe with behavioral abnormalities, but this patient had a occipital lobe involvement and ocular manifestation with cortical blindness. It's like very unfortunate. So we finished the major bulk of those attributable to HIV, but opportunistic infections, and the next we move on to the drug-related ones. See, HIV is such a disease where if the disease doesn't kill, the drug probably might kill. So this is a patient who has severe retinitis with low CD4 counts. You treat them with ganciclovir heart. So I keep using this statement in my cataract talks where I say like it's not over until you say it's over or until the God says it's over, because it can come back with inflammation. So this is a patient who had severe retinitis. You treat them very well, it gets okay, but comes back with inflammation when CD4 counts improve. I mean, it never ends. So it's difficult to manage. This is a patient of an immune recovery uveitis. A patient whose immunity improves, the heart responder, and with improvement in immunity, they can present with an immune recovery inflammatory syndrome. And the same thing if it occurs in the eye, it's immune recovery uveitis. These patients can have all signs of inflammation, cystoid macular edema, ERM, BMT, anything. So you need to balance low-dose short course monitored steroids. And remember that any inflammation is not IRU, rule out infections. So drugs, rifabutin used to be causing, so and it still causes with the improvement in immunity, induced hyperpia uveitis. People are treated with the endophthalmitis-like syndrome. Nevirapine used to be causing Stevens-Johnson-like syndrome. Remember that. And some drugs like efavirenz can cause retinal toxicity. You can have CSR or RP-like response. We have reported a series of efavirenz-associated retinal toxicity presenting with night vision defects. The interesting thing of this is that these patients, these ERG changes actually reverted back to normal or near normal after efavirenz was changed. So that's a good thing. If you can identify early, then you can probably get back the vision of the patient. So continuing about the drugs, I was talking about ethambutol causing optic nerve involvement. This is a patient who had presented with disc involvement and these pale-centered hemorrhages. This was a patient of anemia due to zidovudine, and this anemia caused IH and then disc involvement. So remember, the drugs can also cause devastating vision-related side effects. So uveitis wants to compete anything and everything anywhere. So this was one patient of VKH in a patient of HIV positive. Came with significant pan-uveitis. Maybe it's coincidental or maybe it's an altered immune. Basically, it's some rare presentation of an immune, hyperimmune system disease acting in immunocompromised patients. But if one is not enough, like it's like Dil Mange more multiple or co-infections, it's like cohabiting. You have a severe retinitis, you have a choroidal tubercle. See, these viruses, they say, no, the herpes zoster ophthalmicus does not cross the midline. But this was one patient who had something on the other side also. Then we realized that this is herpes zoster ophthalmicus not crossing the midline very well, so disciplined, but the other side is molluscum. Children, not the young adults, like the famous statement. The one thing that you need to rule out in children is dry eyes and VKC. So vernal keratoconjunctivitis can be aggressive in these patients, and you need to treat them early. So they really resolve after change in ERT for HIV, which lead to demonstrable resolution. So we did a study of screening of kids in the ERT center, and we found that ocular involvement is much lesser nowadays, which is a good thing. Sometimes there are some unexplainable ones. You don't know what it is. You just pray to God. So ultimately, remember that you need to protect patients' vision, but be protective of yourself. Like, no need to be brave or bravado or discrimination or no arrogance. Like nothing happens to me types. So it's a really devastating disease. I mean, like all of us are inspired by him, the person who we can talk hours and hours about the HIV and everything. But this is one person who did it first. It's like who went to Mount Everest on top first types. So remember that he was one who was dealing with this when nobody was dealing with it that frequently. So be compassionate, behave normally, exam with a positive approach, but play safe, double gloving, use all the standard precautions. And if in case you have a needle prick injury, do not panic. So a very, they call it a busy slide, no? A heart immune reconstitution, they say decrease in ocular opportunistic infections, but it's still the most common cause of visual morbidity. In heart era, OI is present differently. You can have newer manifestations like how we saw in CMV. Anterior segment infective lesions can be more. VKC, dry eyes are more common, and newer OSSN type of presentations can be seen. CMVR, toxo are still there, but remember syphilis, that's going to, that's going to be there for a long time. Neuroophthalmic manifestations, not so common in ambulatory patients, but it can be in gravely ill patients. You can have other uveitic entities in patients who are on heart because of their they're coming back to their normal immune status, and that can lead to immune recovery uveitis or iris. Remember, there is something called unmasking type of immune recovery uveitis, where you may not find an opportunistic infection, but it can occur in an organ away from the organ of original infection. Drugs can also cause problems. So PCR and intraocular specimen evaluation are very helpful. So these patients are living longer, so they may have all other age-related problems also. Parting tip, both are risky, so kids behave well. Thank you.
Thank you so much, Dr. Sudharshan sir, for your excellent and systematic and detailed comprehensive presentation of ocular lesions in HIV. We all know that we have learned a lot, not only in this presentation, but all your past presentations that we all have attended, and of course your publications, scientific articles, and Dr. JB sir, and you are responsible for teaching all of us about HIV in the eye. And Dr. JB sir is here. Sir, would you like to comment?
You know, HIV and COVID has taken a lot of things from us, like a lot of lives are lost. But one of the things is a side effect of this disease that we learned immunology. We learned opportunistic infections, how they behave much more than before. And there's a lot of jump in understanding of the pathogenesis of several infective diseases. I really like the talk of Dr. Sudharshan. He has given a lot of new information, which I have heard before. And so a lot of new information, I think it will be very useful for the postgraduates. So with this, I like to, we are still seeing a opportunistic infection in HIV positive patients, and we should not forget. And they do have much more devastating lesions, like a very severe CMV retinitis or tubercular uveitic lesions. I've seen a lens abscess occurring in a case of HIV positive patient, which I can't explain. A lot of very unique cases can happen. The toxo mimicking like CMV retinitis is seen in syphilis presenting as a different format we are seeing out due to the HIV infection.
Yes, sir. And sir has very beautifully explained how to differentiate one condition from other. And I'm sure the PGs will listen to this talk on repeat mode, and there is so much to learn from sir. And Dr. Dipankar, sir, would you like to say something?
Yeah, just congratulate Sudharshan for the wonderful presentation. Now, a few things. For example, molluscum contagiosum, as Sudharshan told, it will be multiple bilateral and mostly the young children. Now, Sudharshan has very nicely showed a fulminant herpes zoster along with molluscum. Again, in microsporidiosis, what pathologically what we are seeing is that in HIV with microsporidiosis, they have a deeper relations, comparative to the other immunocompetent, where probably fumagillin and other medication heart therapy is important. Again, you see OSSN, it is very aggressive in young patient. Whenever you see young patient with OSSN, HIV as a test. Well, I'd like to ask Sudharshan one question. The CMV retinitis, there was a zone of involvement of CMV retinitis when it was described first. There are multiple 3-zone involvement, which will have a worse prognosis. Again, he already told that the CD4 cell count, whether towards lower will have much more aggressive lesion or not. Again, one thing I have observed in toxoplasmosis, they are usually larger lesions. They are usually bilateral. They are usually multifocal, and that's important. And secondly, I want to ask Sudharshan, we are much more concerned with are not multi-drug resistant for TB, though we know that HIV is a multi-drug regime, whether heart resistance he has encountered in those clinical cases in these situations.
Yeah, thanks, Dipankar. Like a few things about the zones of CMV retinitis. It used to be like very popular those days when I started off here fellowship and other things. But I think now it's little more academic, considering that they really present with that's what I was telling. With change in CD4 counts, it is not necessary that they'll have to be involving the posterior pole to cause vision loss. They can have retinitis anywhere else, but the other PVR and other changes can start happening, which can be more devastating. So it's more probably currently the zone involvement is relatively like academic compared to the clinical. We don't treat based on the zones. In any case, we treat them with systemic and then like probably augment with intravitreal. The second thing is about toxoplasma. Yeah, they are like much more larger and multifocal lesions are more often. And what is the third piece?
About microsporidiosis, deeper involvement, deeper corneal involvement.
Yeah, that's what like I used to be thinking that these were they really look some kind of foreign bodies in the inner layers of the cornea types, but then you realize that they are more aggressive. And molluscum, you were talking about molluscum histopathology. What is the difference between adults and children?
I don't think there's difference.
Okay.
There is no such difference between adult and these are size of molluscum is almost same.
The heart resistant ones. Heart resistant ones, like now we have the newer set of drugs. Initially, we started off with the monotherapy with zidovudine, and now like you are again going back to a cycle of we have something like a fusion inhibitor or like CCXR, like some like targeted molecule therapy of heart therapy. So whenever the monitoring, I mean, the best way to monitor is by viral loads. But with the Indian financial constraints, obviously you cannot be doing viral loads that often. When there is not enough clinical response, then probably we go back to the HIV specialist to ask them whether there is a drug resistance. But the monitoring of the heart resistance is by the systemic. It's best to leave it to the systemic disease people rather than to us.
Thank you, Sudharshan.
Wonderful talk.
So with your permission, we'll ask some questions from the postgraduates. So the first question is, what is the pathophysiology of microangiopathy in HIV?
I think the biggest is endothelitis. Like probably and because capillary level endothelitis, and that's causing local ischemia or infarcts.
Yes, you are correct.
Sir. Thank you, sir. And just one more question. How often do we monitor CD4 counts in a clinically stable HIV retinopathy patient?
Depends on the NACO guidelines, say every 6 months. I mean, like practically. I mean, because of the logistics, they probably want to do every 6 months, but viral load is a better way to monitor it.
Okay. Okay, there are a few more questions, but you have covered everything in your talk, sir. Actually, it was a very, very comprehensive talk, and you have already covered everything. And I'm sure if the PGs, if they have missed out anything, they can listen to the recording again. Thank you again, sir, for your time and effort.
Thank you.
Thank you, Dr. JB, sir, for your tips. And thank you, Dr. Dipankar, sir, for your inputs.
Thank you so much. Thank you.
Thank you.
Over to Subhav.
Thank you so much for a very wonderful evening. A very, very comprehensive talk on ocular manifestations of HIV, sir. Before we conclude for today, I have two small announcements to make. There are very, very few seats left for the physical eye focus to be held from 26th of February to 5th of March. So I request all the postgraduates to register without any further wait or delay. And we meet next on 15th of February, the topic being the ocular manifestations of systemic rheumatoid disorders by Dr. Anup. And thank you so very much. A very, very good night to all of you.
Good night.
Thank you. Good night.
Good night.
Good night.
Sudharshan, very good talk.
Thank you, sir.